So today I have a bit of time, and I want to try to cover lots. So, what, are you still awake? Okay, one is I want to talk about some of the issues and challenges that are related to early diagnosis, talk about the early behavioral features of autism at 2, and then also what we know about children under 24 months, and then move toward early intervention and, well, strategies, practical applications for early identification and also for early intervention. My belief, and it has been my belief for a long time, and probably you all believe it too, is that it's really important to identify autism at young ages for many reasons. At the level of the child, we want to optimize child outcomes. We know now from lots of research that an early diagnosis provides kind of a ticket for specialized intervention services, not generic services, but services that are tailored to the unique learning characteristics of children with autism. And that specialized intervention has shown surprising outcomes, I think. I don't think 20 years ago we thought that we would have the outcomes that we're seeing now. Great increases and improvements in social behavior, in adaptive behavior and cognitive skills, developmental levels, language. So there have been dramatic changes in the learning and behaviors of children with autism, young children who participate in specialized intervention. And the very cool thing about this is that it suggests that the core features of autism are malleable. And this is something that we don't have specific evidence related to autism and how the brain actually changes. But we do know from lots of different areas of research, behavioral, social science, neurobiological, that brain development is influenced by genetics as well as experience, that no matter what you come into the world with genetically, there's a range of variation within which the behaviors can be expressed, and that the early years of life are really important times for active brain organization and development. So this is I'm a fan of very simple models, so here's my very simple model of development. So if this is typical development where development occurs, each skill builds on the previous skill, it's a nice solid foundation, and it's kind of straight up and down across, it's vertical. This is what might happen when development early on starts to go a little bit differently. You can have a cascading effect so that later skills don't have that strong foundation and may develop differently. And it's much easier to intervene here where the gap is smaller than here when the gap is larger and behavior patterns are more set. So what we want to do with early intervention and hopefully prevention, which I'll talk a little bit about, is we want to intervene here early so that the rest of development can proceed in as typical a fashion as possible. Secondly, a second reason for early diagnosis is for the families. The behavior of young children with autism can be very puzzling to parents because these kids look like other kids. They act like other children most of the time. But it's very challenging if a parent has older children for whom their parenting skills work just fine, but they just don't understand how to interact with this child or teach this child or get this child to behave. So the diagnostic label or category or word helps provide parents with access to resources and information and support. It gives them opportunities for networking and advocacy. It gives them, it can give them information that will help them know how to interact with and teach their child. And that's an important thing I'm going to come back to. And it can also clarify genetic implications for the family. If families who have one child with autism are much more likely to have another child than other families in the population. So the recurrence risk, and this is from these are old data, but the recurrence risk is of having another child with autism is somewhere between 3 or 8%, and it may be higher than that even. So it's important that families know that. And then third, scientifically, there are good reasons for understanding the early characteristics. If we can sort out the core features from later developing sequelae, I think we'll have a better understanding of what the different subtypes and etiologies of autism are, because now we talk about the autisms and not autism, thinking that there isn't going to be one cause for autism in all children. Then we can delineate different developmental pathways, different developmental sequences for children, and develop treatments that are more tailored to the child, which is another thing I'll come back to. So if we assume, if we can agree that a core feature of autism is some social, emotional, affective impairment, that can be driven by many different things. Underlying that might be a child's social motivation, might be that a child just isn't driven to interact or does not have that, not have the social drive to connect with another person. And that can be measured by social approach and by how much they share positive affect with others, and looking in the brain at social reward systems. It might also be the case that there are attentional and sensory processes that affect a child's development of social affective skills. And that can be, and we know that children with autism have difficulty disengaging attention and allocating attention and shifting from one thing to another. We know that they have difficulty integrating information in the visual and auditory systems. So these challenges can make social understanding in particular challenging because of how the face moves and matching up sounds to what the mouth is doing and decoding those nonverbal facial changes that happen so quickly. Now, these two are certainly not mutually exclusive, so I'm not saying it's one or the other, but they do have different implications for intervention. So if it's a social motivation etiology, then what we want to do is we want to develop strategies and focus early on strategies that will enhance the reward properties of social interaction. We want to make it fun for kids to interact with other people. If it's attentional sensory processes, then maybe we need to develop strategies that are going to help children attend visually and auditory and be able to match up those stimuli coming in from both senses and coordinate that. There are many practice guidelines that recommend early identification and intervention. The American Academy of Neurology was first. American Academy of Pediatrics has been very active. They came out with guidelines or practice parameters in 2001 and have had several other sets of guidelines coming out and actually practical implementation packages. And the latest in 2007 was a recommendation that autism screening be conducted twice before 30 months. So at 18 and 24 months. In the olden days, when I first started in this field, the question was, can we diagnose autism in 2-year-old children? And then now the question is, can we diagnose autism in infants and toddlers? And the shift to that different age range really requires some rethinking and reconceptualization that, again, I'll talk about later. So in terms of diagnosis, the diagnosis of autism is based on behaviors. There are no medical markers. There are no biochemical tests that we can use, no genetic tests. We need to depend on identification of a pattern of behavioral symptoms in 3 areas. One is the way the child interacts with others and understands others. Another is how they use language and communicate with others and understand language and understand communication. And then the third is their restricted activities and interests, which can take many, many different forms. The interesting thing about autism, and certainly not exclusive of autism, is that the symptom expression can take many forms, and it can vary according to a child's age, according to the setting in which they're observed, and then just individual variation from child to child. So the child on the left may be aloof, not like to interact, may be very focused on his own activities, and very difficult to engage. The one on the right may really like to interact, but does so in an unusual way, wants to have friends and doesn't really get why he doesn't have friends, and doesn't have an understanding of social rules and expectations that others have of his behavior. In terms of time, at age 2, the child may not make good eye contact at all, may not be able to imitate actions of others, may not show any interest in a younger sibling or in interacting with peers, may not have developed language yet. And the same child at age 10, it's a real different snapshot. Increased social interest, has learned how to imitate appropriately, but the differences are more in perspective taking, understanding what another person is thinking or feeling. Conversations, although language has kicked in and is functional, conversations aren't really focused on that mutual exchange of ideas. They're more focused on the child's particular interests. And then across settings, if we look at a child in a highly structured setting with a lot of scaffolding, we may not see anything that looks unusual. Whereas if we observe a child in a less structured free play setting, we may see some of the behaviors that we associate with autism, but as I'll say later, are not really important for the diagnosis. There are 5 disorders in the Diagnostic and Statistical Manual, but when we're talking about young children with autism, which I am, we're really talking most commonly about autism and PDD and OS. So when I say autism, I usually mean both of those together. It's easy to read diagnostic criteria and to say, oh, that sounds easy. But when you're looking at a child under 3, there's a lot of behavioral variability that you don't see in older children. Self-regulation isn't always there. Children, if they're in an unfamiliar setting or they are hungry or they're not feeling well, you may see behaviors that are not typical, especially in a one-shot diagnostic setting. There are overlapping symptoms with other developmental disorders, language delays, developmental delays that can cloud the picture. And then the current diagnostic systems and measures aren't really designed for very young children, and they don't work that well. So in the DSM criteria, 2 of the criteria, well, one is peer friendships. You have to measure a child's peer friendship, and then also you look at speech abnormalities. Now, the prototypical 2-year-old with autism may have a mental age of 14 to 15 months and a language age of maybe 12 months. So it's really hard to judge peer friendships in a child at that developmental level, and certainly to identify speech abnormalities when the child doesn't yet have much language. In the ADOS, they are working on a toddler form, the ADOS-T, but in its what's currently available in the ADOS, there are some findings that it over-identifies children at age 2. And then the ADIR wasn't designed for children with mental ages under 18 months, which many 2-year-olds have. And also, it takes quite a while and isn't necessarily practical for clinical settings. So we have a bunch of kind of disconnects in terms of diagnosis. One is that we're pretty sure autism occurs and is present early in life, and the diagnostic criteria, diagnostic manuals, at least since 1980, have indicated that. But the criteria are still based on characteristics of children at preschool age or older. And the other disconnect is that parents notice something is wrong. They may not notice autism, but at an average age of 17 months. And the average age of formal diagnosis in this country is still 3 to 4 years or older. So we have a way to go in terms of applications of diagnosis. One of the questions I always get is, at what age can we diagnose autism accurately? And when we think about accurate diagnosis, we think about reliability and how well clinicians will agree about the diagnosis for the same child. And we also think about stability. So if you give a diagnosis at one age, is that diagnosis going to be there at a later age? Now, the stability question is it's kind of an interesting question, because if intervention works, then they may not have the diagnosis later on. And so that's a little sticky issue, and it's very hard to tease out whether it was a misdiagnosis, whether it was the natural course to improve, or whether intervention did what we all think and hope it will. In terms of reliability across clinicians, this is from a study that we did, and we did not even look at this systematically. We had a few clinicians who saw each child, but it was not it was not a big study of reliability. But we did find that that when experienced clinicians looked at the same child, the agreement was good for whether or not a child was on the autism spectrum. So that would be autism or PDD-NOS, and that was 89%. When you tried to make the finer distinction between autism and PDD-NOS, it went a little bit lower, but not much. But when we compared a clinician who didn't have experience with young children and less experience with autism compared to an experienced clinician, the agreement was actually below chance level. So experience really is important. Okay. We've learned a lot about diagnostic stability over time, and starting by the mid-'80s, there was good indication that at preschool ages, the diagnosis was stable over not just the short term, 1 or 2 years, but also the long term, which would be probably five and up. By 1995, we had some indications that the diagnosis in 2-year-olds was stable over the 1 or 2 year period. And then by 2005, we had some indication that that 2-year-old diagnosis would be stable over a longer term, like 5 to 7 years. So that seems nice and all wrapped up and in a nice little package. And this was one of our studies where we followed up children. We saw children at 2, 3, and 4, followed them up to age 10, 9 or 10. Yeah. And found the stability was 88%. And the 88, that's about what, I mean, that's good stability. That's about what you expect to find. And that of the 3 children who did not receive a diagnosis on the autism spectrum, 2 of them did show other learning or behavioral problems. We also found at that time that better cognitive and language outcomes were associated with younger ages. And we formed outcome groups based on cognitive and language skills. So we had a better outcome and a less better outcome. So younger children who are identified earlier had better outcomes. Children who had initial age 2 cognitive and language skills that were better fell in the better outcome group. And interestingly, and we've never replicated this, but the children who had more speech and language therapy from age 2 to 3 ended up having better outcomes. And I think that's a fluke of this like amazing group of interventionists we had at the Bill Wilkerson Center at that time. So, okay, so that was in agreement. Here's the package that we think is all wrapped up. In a more recent study following children from age 2 to 4, so I was one of those people saying, okay, it's stable at age 2, right? So we do another study. We see children, like, I don't know, recruit them 7 or 8 years later, follow them for 2 years, and we find the stability of staying on the autism spectrum was only 63%. So this is one of those times where you just want to crawl into a cave. And I did for a little bit, and then tried to figure out, okay, what is this? And it turns out that of the 18 children didn't meet the diagnostic criteria, but 17 of them still had a language impairment or a developmental delay. So we looked at what predicted the symptom improvement, like what characteristics at age 2. And to me, the important thing was, again, because this replicated the earlier finding, is that the younger age at diagnosis. If the initial diagnosis was less than 30 months, these children were much more likely to leave the autism spectrum. And for the children who were over 30 months, the stability was just what it is for, you know, what has been reported in the literature was 87%. So to me, it looks like children under 30 months are much more likely to leave the spectrum. So the younger children may have less stable diagnosis. We also found that higher cognitive scores were associated with leaving the spectrum. And when I say leaving the spectrum, I mean failing to meet diagnostic criteria consistent with an autism spectrum disorder. Also having less severe symptoms at age 2, which you would expect. You expect children who are milder are gonna do better. But we didn't find any relation between gender or race or SES or intervention or the initial diagnosis, whether it was autism or PDD-NOS. Those did not predict outcome category. So to summarize what I've said so far in terms of accuracy, the diagnosis is reliable across clinicians from, again, the data aren't great, but from 24 months. It's stable over time, maybe from 30 months. But there are lots of things we do not know. So we don't know yet the diagnostic reliability and stability under 24 months. And that's really important because the field is just like in a wind tunnel. How does that one come to mind? It's just like moving very quickly. And we really don't know if the diagnosis is stable at those young ages or if it's reliable at those ages. And we certainly don't know why some children improve and others don't, whether it's the natural course, whether it's intervention, what the risk and protective factors are, and whether we're just seeing a different set of children now than we saw 10 years ago. With the greater awareness, maybe there's just like a different cohort. The behavioral features, I'm going to describe them for age 2. So we've learned a lot over the past 10 years about these characteristics, and we've been able to learn about behaviors at 2, because both retrospectively looking back, asking parents of older children what their child was like at 2, but also or doing a record review, but also we can make the diagnosis at age 2, so we can ideally talk to parents about their child's behavior before they get the diagnosis, but then make the diagnosis at the same time. So we're all talking about the same time period. And to cut to the chase, what we have found is that the behavioral symptoms in the areas of social and communication domains are the most reliable clinical indicators of autism at age 2. And these are supposed to be red herrings, but I just was in Seattle and was informed that these are not herrings. So don't remember what they said they were, but just in case, I know you fish here. I don't want to get this comment again. Behavioral symptoms only in the area of restricted and repetitive interests are not reliable clinical indicators of autism at age 2. So if we have to focus on the social communication deficits, this is where it gets a little bit tricky, because social and communication behaviors are not, they're negative symptoms, they're not positive symptoms. They're things that aren't occurring. They're things that we're not seeing. They're expected behaviors that these children are not demonstrating. And that, if a child doesn't imitate during an office visit or doesn't smile at you when you smile, at them, you kind of cut kids slack. Okay, maybe they're having a bad day. What does it mean if a child doesn't do something? On the other hand, positive symptoms like flapping and spinning and unusual behaviors that we sometimes see, those are positive symptoms. Those are easy to see. They're easy to recognize as unusual, and yet they are not as important in the diagnosis, especially if they occur in isolation. The other thing is that how do we define social reciprocity? We don't have milestones for that. We know when kids are supposed to walk, when they're supposed to talk, but how do you tell a parent, like, okay, your child has to wave goodbye at this time, or has to smile back at you at this time, or what percentage of time they have to smile back at you at this age? So we don't really have the same kind of cultural guidelines for that. And then also, parents are really good at extracting the best behavior of their child, and they often do not realize how hard they're working to do it. They will figure out ways to engage their child. So that makes it a little bit hard to go from parental report alone. This is an example of positive symptoms. So this is a doctor talking to a man who has cows growing out of every part of his body, and he says, "I'm afraid you've got cows, Mr. Farnsworth." So this is what autism is not like. This is what it might look like in a child who, if he did this behavior over and over and over again, a positive symptom. But again, this isn't what we find in autism at these young age. I mean, we may see this behavior, but it is not in itself critical for the diagnosis. So when we think about the characteristics of autism, we have to understand the framework of typical development. So what we expect socially of 2-year-olds is interactions that are rich, they're dynamic, they're back and forth, they're spontaneous, they are synchronous, they're and naturally so. There's mutual engagement, there's shared enjoyment. So with adults, we see them, they imitate spontaneously, they show off just to get attention. This child has, I don't know if you can see, has like stickers on, he puts stickers all over his body and is like proudly showing them to his parents. They show over on the right, they initiate and respond to social games. And the child, I mean, this child in the upper left, I mean, that child just draws you in. I mean, it's a smile that just makes you want to respond. With peers, they show interest in other little tiny human beings or same age children or older children. They imitate, they play together. This picture on the right is one of my favorites because these two kids in preschool are playing this ridiculous game where the one bites the end of a banana and the other bites the other end of the banana, and they are hysterical. And the child who's watching them is, you can't see his affect, but you would guess that he's smiling and enjoying the game also, probably hoping for a turn, which 2-year-olds are not good at doing. So with autism, those are the things we don't see so much or so consistently. Children are less responsive to social overtures. They're less likely to participate in back and forth play. They don't show off for attention. They don't imitate as well, and they're just not as interested in other children. But again, this is an important point. Social behavior is not all or nothing. It isn't like these children don't ever look at you or smile at you. It isn't that they don't ever imitate your activities. It just doesn't work that way. It's that they show these behaviors less of the time, or it requires more effort to elicit them. In terms of communication, we can think of communication as the functions or reasons that children communicate. So we can communicate because we want something, because we want to let you know we don't want something, simply to share enjoyment with another person, or to share in terms of letting them know that you're enjoying this activity during a peekaboo game, looking at you and laughing, or to direct attention to objects or events of interest. And this is joint attention, and this is turns out to be a really important behavior at young ages. But examples of this are pointing to something that I'm interested in and looking back at you and making sure that you're looking also. Or holding up, scribbling on a piece of paper, holding it up to show you and waiting for your response. That is a beautiful piece of artwork. Okay, we can also think about the forms of communication, and surely language is one of what we think about, but there are all different kinds of ways that infants, before they acquire language, ways they learn to communicate. They use gestures, they use eye contact, they use facial expressions, they vocalize before they get words. So here are some examples of children communicating to express, to request, to express their desires or needs. There's reaching, there's pointing, and for an object or to be picked up. And you don't need words to do that. And then these are examples of communicating to share interest and direct attention. There's pointing, there's another pointing, and then there's holding things up to show. And as you can see on the bottom right, it occurs at very young ages. Okay, so this is joint attention with Dick and Jane. And this is important because my colleague, Pat Levitt, has concluded that there are more children with autism now because we don't have Dick and Jane books anymore. But if you look at a Dick and Jane book, things like this are all over it. There are kids pointing things out to other kids. You know, we pay attention to the words, but it's like, what are the words? See, spot, run. I mean, it's all about joint attention. So keep that in mind. So for example, so this boy is pointing, that's initiating joint attention, and these kids are all responding. So they're responding to joint attention. And those are, again, those are key core deficits in autism. Okay, so in terms of the forms of communication and how we communicate our needs, young children naturally, spontaneously integrate different forms. They combine eye contact, facial expressions, and gestures. And they have lots of different facial expressions. I mean, they can, and you can read them, read their thoughts, intentions, feelings by looking at their faces. So examples of different ways to get what you want. This child is reaching for something with eye contact. These children are taking an adult's hand, one to put it on an object, one to take them to the door, and not very social, no eye contact, no way of really communicating to that person other than taking that person. And then this was an extreme. These are real photos. Some of them are staged, but these are real. So this child, and this was in clinic, this child wanted something that was on top of that cabinet, uses his mother as a chair, and climbs up on her, as if she weren't there. There was no attempt to communicate his desire to her first, and is holding onto her hair as to stabilize himself so that he can get that bubble gun that's up there. So, these are different levels of socialness in communication. So we see less. The red flags are less communication, certainly to direct attention, less gestures, less eye contact, and also inconsistent response to sounds. The American Academy of Neurology practice parameters also point out these red flags. They're in your handout, so I won't mention them, but these are really important and suggest a need for referral for evaluation. In terms of the third characteristic of restricted and repetitive activities, that's actually the converse of using toys and playing in a typical way. We usually see children at 2 play with a variety of toys, use them functionally, use them flexibly, create different play schemes, act out real-life scenarios. And then in autism, we see less functional play, less imaginative play. Those are the most common. And then we may see repetitive motor behaviors. We may see unusual visual interests. But again, these are not critical for the diagnosis. So just examples of some liking to watch wheels, lining up puzzle pieces in the same way each time, and just liking some visual stimulation of that slinky. So this is a test. If at age 2, if you see a child who has social communication deficits and restricted activities and interests, is that a red flag? Yes. Okay, social communication deficits but not restricted activities and interests. Is that a red flag for autism? Yes. What about no social communication deficits but yes, restricted interests and activities? No, that's a red herring or flounder, whatever it is. I know it's not a flounder. Okay, under age 2. So if we're looking at characteristics under age 2, we have some unique challenges. And the challenges come in how we're going to identify these features. So this is how, so in 2-year-olds, remember, we can look retrospectively, which we can still do, but we also have the advantage of concurrent reporting because we can identify the characteristics at the same time we're making the diagnosis. But for under 2, we cannot do the concurrent because we don't really have diagnostic methods for children under 2 yet. So we've had to be very creative. And so retrospectively, the use of looking at early home videotapes, Jerry Dawson brought that methodology to the autism literature, and that's been very, very helpful. But also we've developed ways of, what we're really trying to do is predict, is this child going to end up with the diagnosis? So what we do is we use high-risk populations, and those can include children who have failed a screening, a developmental screening or a language screening, or children who are younger siblings of children with autism. In both groups, they are at elevated risk for developing autism. We can we can look at their behavior at young ages, but we have to wait till they get to be 2.5 or 3 before we really can make a more secure diagnosis. so it's expensive. So what we're finding under 24 months is that there is that reduced social engagement, very similar to what we see in in 2-year-olds. So we don't see as much attending to a name. We don't see the following the point. These children are less likely to look at others, less likely to share their enjoyment with others, and less likely to direct attention. So in terms of responding and initiating socially, we're seeing impairments. But at this age, we're also seeing atypical visual and motor behaviors. And the interesting thing is, so these are the things that we don't emphasize at 2, but we're measuring them very differently, and we're using different paradigms in these younger children and looking at much more finely defined skills, which may account for this difference. So we're seeing the younger children tend to have unusual or visual tracking and visual fixation. They may have, and these are things that have been replicated. So at least 2 studies have found this. They may show increased visual attention to objects, unusual motor mannerisms, and repetitive actions with toys. So these are things that, when you measure them in a certain way, you can see under 24 months. I'm a big fan of studying younger siblings because I think for lots of reasons. First of all, it enables us to understand the earliest behavioral markers of autism, and we can actually start before the child is born, but we can really start at birth and track development of different domains over time, hoping to find something very early. And not just, this says behavioral markers, but also I would add neurobiological markers as well. We can understand not just the risk for autism, but also risk for what people call the broader autism phenotype, which are similar behaviors, but maybe not at a clinical level. We can study developmental course by starting young, including regression, try to understand that phenomena. We can look at potential genetic, underlying genetic and biological influences and mechanisms that may be responsible for different sequences of development. And we can also assist families by of parents who have one child with autism are often very vigilant about their subsequent children. They know about the elevated risk, and it can be very helpful to them to monitor the child and provide referrals when needed. And this is one of our babies on Newsweek, and she ended up fine, I'm glad to say. There are at least 2 different kinds of sibling studies. One is looking at the outcome. So we follow up the younger sibling, we collect behavioral data early, follow them up, look at what their diagnostic outcome is. We're interested in how many of these children receive a diagnosis of autism or other disorders, and also which early behaviors or processes or trajectories predict these diagnostic outcomes. Then another approach is to compare groups of children who are younger siblings and groups of children who are younger siblings of children with autism with groups of children who are younger siblings of children with typical development or of older siblings that have another disorder, but more commonly it's typical development. And that gives us information not so much about outcomes, but how children who are at elevated genetic risk differ from those who are not on behavioral or neurobiological measures. And what we're trying to do is look for potential endophenotypes, which are markers that aren't diagnostic necessarily, but that occur more commonly in families with some genetic vulnerability, and are very helpful in genetic studies. So there are advantages to both. In terms of the group comparison research, what studies have found now is that and this is several studies, as a group, the younger siblings of children with autism, I think I'm going to start calling that high-risk siblings versus low-risk siblings. The high-risk siblings demonstrate weaker cognitive skills, affective skills, social communicative skills at least as young as 14 to 18 months compared with low-risk samples. And these differences don't seem to be accounted for by the children who, in that group who end up with an autism diagnosis. So I'll show you some of our data on that. We had a sample of, a high-risk sample of 64, a low-risk sample of 42. These children were recruited from 12 to 23 months. Their average age at the time I'm going to talk about it was 16 months. And we found differences in all of these domains. In terms of cognitive, we found differences in the MULLEN visual reception. This is a cognitive test of nonverbal problem solving, as well as the total score on that test. We found on the MacArthur CDI, Child Communication Development Inventory, we found differences in the number of words the children, and this is a parent report measure, the number of words that the children understood, the number of phrases that they understood, and the number of gestures they used. On lots of different social or behavioral measures, we also found differences. The DAISY is an interview of early dyadic skills and social relating. The CARS is an autism symptom checklist. RJA is a responding to joint attention task that we have, and that task is set up. I knew I would wish that I put this slide in. So the task is set up so that if you're the child, there's a large wall with 3 shelves, and there are 9 spaces for toys to be placed, except that the bottom middle is a camera instead of a toy. So the examiner is sitting next to you and giving some combination of verbal and nonverbal cues to try to get you to look at what he or she's looking at. And so, and then the variable that we use is the percent accuracy in finding the right location. So that's there are differences between high and low risk children in that. In the STAT, which is our screening, we have a directing attention section that's 4 tasks, and they score lower on that as well as the total score. So there are lots of differences. Now, these differences aren't like really in the clinical range. I mean, it's not like they're below average, and many of these don't have a cutoff. But they're significantly different statistically, so something suggesting that something's going on, but we don't necessarily know if it's important. It turns out that these results are not just due to a few low performing siblings. On the MULLEN, for example, the cognitive measure, we looked at the percent of children who had at least one subtest score, 1 standard deviation below the mean, and there were more high risk than low risk children who did that. Even we looked at the STAT, children ending up in the at-risk range, more children in the high-risk group, and in the communicative development inventory, many more children who were reported to understand less than 10 phrases in the high-risk group. And these numbers are important because 53% or 30% are not, that's not the percentage of children who are going to go on to receive a diagnosis. That's much too high. So, you know, we don't really know. I'll be the first to say whether this means anything. We don't know whether, we know statistically there's significance, but whether there's clinical significance, we don't know. Do these differences predict, are they a risk factor for the development or for later diagnosis of autism or for the broader autism phenotype? Is this group going to improve over time? I mean, is this just like a little developmental blip and their genetic vulnerability creates some need for more experience to acquire these skills and they're showing delays right now? Or is intervention needed? I mean, are these subtle differences early on going to cascade into bigger differences later on? And we will wish that we had intervened at some early point. So those are questions that we're facing in the field. There are also some interesting scientific implications, potential scientific implications from the group comparison studies. So we've thought that the social impairments of autism, that underlying the social impairments is a decreased attention or decreased interest in social stimuli. There have been some interesting studies with 6-month-olds or 6 to 9-month-olds that suggest, well, maybe we want to think about it a little bit differently. So Daniel Messenger at University of Miami used the face-to-face still face task, which is a parent-child interaction, and found that the high-risk children spent the same amount of time looking at their mother's face as the low-risk children. They spent more time looking at other things. And then Julia Noland is at Vanderbilt, and she used a working memory task that's like peekaboo. There's a shield, and either a social or non-social stimulus appears to one side or on the top, and the task is to see whether children look. So a stimulus appears, disappears, their attention is drawn to the center, and then the task is to see whether the child looks at where it last appeared, which would suggest that that they have a representation of that, whatever it was, or a motivation to find it again. So she found that that this working memory, looking at that working memory was equivalent across the groups for the social stimuli. So there wasn't an impairment in the high-risk group for the social stimuli. But the younger siblings were better. They performed better for the non-social stimulus. So again, just finding similarities in attention to social. Maybe it isn't that there's a decreased interest or motivation in social, but maybe there's like an increased interest or attention to non-social stimuli that's driving autism. So these are questions that we're just going to have to try to figure out in the next 6 months, no, in the next while. I'll let you know. Just email me. Okay, so we also did the other kind of study, the follow-up, where we followed up, and it's the same children, but we had 49 in this sample, high risk and 30 low risk. The mean age was 15 months, and the children had 5 different evaluations, 5 different visits over a 1.5-year period. And we included children who only had at least 3 of the 4, because we wanted to look at predictors of that time 5 diagnosis. So at time 5, they were between 29 and 44 months when they got a diagnosis. So we started out using these outcome categories and definitions. So autism, and that was, we used the ADOS, the ADIR, and the DSM criteria, and it was a clinical diagnosis. Same with PDD-NOS. We had a category of developmental delay, and we defined that with scores more than a standard deviation and a half below the mean. We had a language delay definition. You couldn't have developmental delay. It had to just be the language that was impaired. And then we had a group that was no diagnosis, none of the above. And as we started seeing these children and following them up, we felt like something was missing. And because there were kids who the clinicians didn't really feel comfortable saying no diagnosis or because that conveyed that the development was more typical than they felt it was. So we added this and defined very carefully this, and we called it broader autism phenotype. I don't know that that's what it is, but it sounded better than in-between group. So, and this group couldn't have autism or PDD-NOS. The clinician had to have concerns, and then they had to score above a certain level on the ADOS, or else had received an autism spectrum diagnosis, like at a previous visit. And that was only one child. So we tried to kind of quantify and define what it was. So this is what we ended up with. In the column on the right, the low-risk siblings didn't end up in any of these categories except the no diagnosis category. The SIBs, the high-risk siblings, 12% ended up with a spectrum diagnosis, some with developmental delay, none with language delay, the way we defined it. And then we had 16% in that in-between group. But really, so the vast majority looked fine. We looked at their performance at endpoint on the MULLEN scales, and we used the total. I'm going to just show you the total. scale for that. That's cognitive. And for social, we looked at the directing attention score on the STAT, as well as the responding to joint attention measure that I described before, how accurate they were. And I'll show you pictures of this, but the bottom line is that the high-risk children who didn't get a diagnosis, who were in the no diagnosis subgroup, were very similar to the typical children on both cognitive and social measures. The children with, who ended up with an ASD diagnosis, they showed their differences from the other groups really increased over time, and they showed a decline on cognitive, and these are standard scores, and they showed minimal growth, if any, on social measures. And then that in-between group is very interesting because they really showed intermediate performance. So cognitively, they were similar to the kids who were developing okay. So this is a group of children who have like better cognitive skills. But in terms of the social measures that we used, they were similar to the autism group at time 1, but then did show more growth over time. So go figure. So cognitive, this is what it looked like. The top 2, I don't know if you can see colors, but the purple and the green are the more typical groups. The light blue on the bottom is the autism ASD group, and then the red one in the middle are the children we called BAP. No differences between any of the groups at 15 months, and then by 34 months, the autism group was lower than all other groups. Responding to joint attention, at time 1, the autism group was lower than the typical groups, the groups with no diagnosis, and the broader autism phenotype was also lower than the typical development group. At time 5, the autism group was different from the typical groups, but the broader autism phenotype group had improved so that they weren't different from the typical groups at time 5. And you can see the rate of growth of that red middle line. And then this similar here. Time 1, the broader autism phenotype group was lower than the typical and very similar to the autism. And then they shot up. They showed an increase, and they were still a little bit lower than the children without a diagnosis, but they were better than the children with autism. So they're really different developmental trajectories for these groups, which we'll also figure out in 6 months. But it's just food for thought, and it illustrates the variability in this group and of potential import for genetic studies, but also for thinking about what we do clinically. So to summarize where we are in terms of diagnostic accuracy under age 3, for 2-year-olds, we have a really good understanding of behavioral features. We have a pretty good understanding of diagnostic reliability, and diagnostic stability is good, especially at 30 months and above. For under 20 months, we have an emerging understanding of the behavioral features. We don't really know about the diagnostic reliability or the stability yet. So that's where we are. So I have 4 minutes now, so I'm going to start on this, and then I'll be able to stop whenever you tell me to. So let's talk about some practical implications. First of all, in terms of assessment. First of all, clinician experience is important. It is not easy to identify autism in young children, so working with people who have a specialty and lots of experience in this area is important. We also need to be very careful about making an early diagnosis in terms of whether it's going to stick, and that the implications for what we tell parents are very important. I say completely different things to parents now than I said 10 or 15 years ago. I mean, right now we're seeing a snapshot of behavior. Lots of things can happen. Some children no longer meet the diagnostic criteria for autism. In 1 or 2 years, intervention, we know how to do, intervention is what we know we can do to try to help that. and there's great variability in course. And then just also the need to monitor later-born siblings, not just for autism, but for some of these subtle behavioral things. So here is our service delivery model right now. So in the ideal. So you do some kind of screening. If the screening indicates at risk, then you refer and get a diagnostic evaluation. And then if the evaluation suggests autism spectrum disorder, then you get specialized intervention. Is it similar here? Okay. So it's like that roughly in many states. Okay, but we have some challenges with this model. One is that we don't always get to the screening part, which means that we can't always get to the diagnostic evaluation. And the end point isn't the evaluation, of course, it's the intervention. So we're always trying to get to that intervention part. So the reality, according to several surveys, is that less than 50% of primary care physicians use a validated developmental screening measure. This isn't even an autism specific, but just to screen for development. 8% screen for autism, and there are lots of real barriers for screening for them, including, just how to bill for it, having the time for it, feeling competent in doing that. And then there's a real disincentive of alarming parents and then having them not be able to access resources in the community. So if they say that goes fine, they get to the evaluation point, so they get the referral. Okay, then I don't know about here. It takes a really long time to get a diagnostic evaluation where I am, and in most places where I speak. So that's a problem. By the time they get the evaluation that makes them eligible for services, they've aged out of the birth to 3 services, often, not always. So here's another way to think about things, and this is if you're not getting, and this is like the use of novel use of screening methods. So if you're not, which is what I'll talk about later. So is there a way we can think about a different way to screen so that we can get to that specialized intervention? So here's where we left off, is that I'm proposing that there's a model that includes that involves novel uses of screening measures. So I want to talk about screening as compared to diagnosis. Diagnosis, as we know, requires advanced clinical training, specialized experience. It involves integrating lots of different pieces of information, evaluating behavioral symptoms within the context of family history, developmental history, cognitive level, and it involves a bit of training. Screening is different in that we expect screening measures to be usable out in the field by a broader variety of people with minimal training for the screening measure. The measures are usually pretty easy to design and interpret and score, and you end up with not a formal diagnosis, but you end up with a risk. There's a cutoff score, and you end up with a child score that's either at risk or not at risk for whatever it is you're measuring. So there are very important differences, and the most important is that a screening tool does not provide a diagnosis. It provides, it tells you whether a child is at risk or not. I think screening is really important for early identification and potentially for intervention as well. So I want to talk about characteristics of screening measures. And the bottom line is that there are different measures are better, different types of screening instruments are better for different settings. And I think we can be creative in how we use them. So a measure can be either broad-based or autism-specific. It depends what you're screening for. If you want to screen for general developmental delays, you can use some measures. If you want to screen for autism in particular, you would use a different measure. They can be parent report versus some interactive or observational type, and that depends on how much training you have. They can be level 1 screeners or level 2 screeners, which is associated with where you're conducting the screening and who you're screening. So level 1 screening is the goal is to identify children at risk for autism from those in the general population. So this usually occurs in primary care settings, so physician offices, for example. Level 2 screens are designed to identify children at risk for autism from children for whom there are also concerns. So you're trying to tease out the children at risk for autism from those who may have language disorders or developmental delays without autism. And that usually occurs in referral settings. It might be a speech clinic. It could be a diagnostic assessment center that has a screening clinic as part of it. There are lots of advantages and disadvantages of both parent report and observational interactive screenings. Parent questionnaires are great in that they're very convenient. They are often brief and don't take a long time to do. They don't take a long time to score. The parent is familiar with the child across history and settings. The drawback is that the parent has to be able to not just read, but also to understand the intent behind the questions. And it's not so easy to develop questions that, that are understood by others the way they are meant. And also there's the potential for biased reporting from a parent, which can go either way and can be intentional or unintentional. In terms of observational or interactive measures, it's, seeing a child is real different from reading about a child. So you have the advantage of being able to lay eyes on, lay hands on. And you can also get some more qualitative information that you can't get from trying to read between the lines of a questionnaire. Drawbacks are that they may have training requirements and they usually take longer. So in different settings, some are going to make more sense. These are the screening tools, for the autism-specific screening tools that are available now. So for parent report at level 1, there's the MChat. I'm going to have a list of acronyms and references that they're going to put on their website. So I don't even know the names of all of these, but the MChat is the modified checklist for autism in toddlers. So I'm just going to use the initials now, and then later we'll fill in the blanks. PDDST, the ESAT, of these, the MChat has the most research behind it, and so I'm going to talk a little bit about that one. And in level 1, primary care settings, parental report measures make more sense. Physicians in most practices don't have the time to add an interactive screening to their repertoire. They need something that can be done quickly. Interactive measures, again, there are level 1 and level 2. Again, without going over each of these measures, in referral settings, that's the place to use interactive measures. And the 2 that are available now are, well, 1 is available now, the STAT, and that is ours. I'm using it as an exemplar. It doesn't mean that it's the best or it's perfect. It means that I know it the best and that there's research on it. The AOC is something that Lonnie Zwigenbaum is developing for very young children, based on his work. He's in Canada, based on his work with younger siblings. So that is not yet quite ready for. We don't know the screening properties of that quite yet, but it's coming up. So I'll talk a little bit about the MChat and also about the STAT. So the MChat, which was developed from, so the original screening was the chat, which was developed in England by Tony Charman and Simon Baron-Cohen and Tony Cox, and lots of people who, and it was a great measure and a great concept. It had a parent report component and an observational component, mostly parent report. And it turned out that the screening properties weren't good. It missed a lot of children. So Debbie Fine and Diana Robbins developed a modified version of the chat that's all parent report. So they used some of the chat items and added some. And it was designed as a level 1 screening, so for primary care settings. It consists of 23 items that are parent just circles yes or no. This is in public domain, so they can post a link to it. It takes about 5 or 10 minutes for parents to complete, 2 minutes to score, and it was developed originally for children between 16 and 30 months. There are lots of articles. This group has been very productive and very good about studying this instrument in an objective way and learning and trying to understand its advantages and its liabilities, and also trying to work on the liabilities. What has become apparent, and this is an important message for any of you who are any of you using it now? Okay, so close to none, but 1, 2, 3. And in the other sites, I can't see you. No. So anyway, what is important, and that's become more apparent recently, is that the screening has got to be, you've got to use the follow-up interview that they developed to go with it. If you do not use the follow-up interview, you're going to over-identify too many children. So this is a plug for if you're going to use the MCHAT, which is a good measure to use. It's fast. It's the best one that we have now for a parent report screening. You've got to use it with the interview. What this slide illustrates is that, first of all, that it works better in high-risk populations, so which are actually second, which would be a level 2 screening. But it still works okay in low-risk populations if you use the interview. If you don't use the interview and you use it in a general pediatric practice, you're going to over-identify tremendous numbers. The positive predictive value is so these numbers are the proportion of children who screen positive who actually have autism. And so if you subtract 1 minus that number, that's the percent that are over-identified. So you can see without the interview, in a low-risk general pediatric population, you're going to over-identify like 80%. So that's not good. But when you use the interview, the numbers are much, much better, and better than other screenings that we have. This is to illustrate that the children who are most likely to be missed using the MCHAT are those who are the young low risk. So it isn't just the low risk, but the younger children. So the children who had an average age of 18 months, the positive predictive value was only 0.28, which means that 72% were over-identified. So it's over-identifying younger low-risk children. So that's just without the interview. No, that's with the interview. So this is important to know just if you're going to use it. And I think you should use it, and you should look at the articles and just use it wisely. But it is the best that we have. And then for the high-risk populations, it functions much better. So you want this positive predictive value you want it to be around 80.80. But so this is pretty good. So for the interactive screening tools, the advantages of these I've mentioned a little bit, but if you're doing an interactive screening with a child and the parents there, you get to talk to them about what you're doing and what you're looking for. You get to find out if it's a typical day. You get to find out about what they're concerned about. You get to find out, you get to tell them what you're concerned about. You can use them as teaching tools. You can use them and also to plan intervention activities and goals. Because if you're looking at those core developmental skills, you're getting lots and lots of information about the skills that you can then use for interventions. So I'll tell you a little bit more about that. So the STAT was designed as a level 2 screening tool, so for referral populations. So for children there's a concern about them, you want to know if it's likely to be autism, so you may use the STAT. There are 12 items. They're play-based, interactive. The items assess social communicative behaviors, requesting, directing attention, imitation, play. Takes 20 minutes, takes training, and it was developed for children 24 to 36 months, and there's some indication that it can be used for children as young as 14 months. The psychometric properties are pretty good for 2-year-olds. And again, emerging evidence for younger than that. So this is what the items look like. So there are 2 play items. One is looking at functional play with a doll. One is looking at interactive turn-taking game with a ball or a truck, rolling it back and forth. And so what we look for is whether the child combines related objects, arranges objects into schemes, uses toys functionally, joins in turn-taking play, shares enjoyment. And these aren't even the things that are scored. These are the behaviors that you have the opportunity to observe within this structured press for behaviors. Imitation items are, you saw some of them, you saw shaking the rattle. There's also drumming hands. You saw hopping the animal. There's rolling a car back and forth. And so in addition to whether they pass or fail this, we can look for how well they attend to the examiner's actions, whether they try to imitate, whether they are able to imitate successfully, and whether they attempt to draw the examiner into these activities. And you saw some examples of children who did and didn't do that. There are 2 requesting items. You saw maybe just one of them. You give a child a desired object, and it could be food treats, it could be bubbles, we use both, and a sealed jar with a tight lid. And again, you look for whether they request, and if they request, how they do it. And so we can look at eye contact, whether they use gestures, whether they vocalize, and probably most importantly, whether they combine these different nonverbal or nonverbal and verbal behaviors to make that request. For directing attention items, we have 4 items. One of them is we hand the child a bag that has 4 toys in it. It's an opaque bag. It has 4 toys. We kind of pull one of them out, and we say, here, you can play with these. And what we're looking for is whether the child will take out a toy and show it to the examiner. The other 3 directing attention activities are kind of weird stuff that we make go on to see how the child reacts and whether they engage the examiner. So you saw the balloon, so we let a balloon fly across the room so they can share their interest or surprise with us. We have a noisemaker that sounds. The examiner sounds it from underneath a table to see if the child will look around or indicate surprise or try to find out what that is. We have the examiner like puts a puppet on her hand under the table and then starts writing with a puppet on her hand. That's not the best item for the young kids, but that's what we do. So those are examples of directing attention. So we're looking for whether the child communicates something to the examiner, enjoyment, surprise. We're looking for positive affect here. And how they do it, whether that's eye contact, facial expression, gestures, and again, more importantly, how well they're combining them. So my point here is that you can present, you don't have to use the stat to do this. You can present these items and have a little checklist of what it is you're looking for and then build from there. So if we have this model and there is screening, okay, so the child gets screened but there's a really long wait, then maybe the physician's office or nurse practitioner, whoever's doing the routine screening, can refer to community providers who are going to use a level 2 interactive screening and can get the information that they need to at least get the child started without a diagnosis. Okay, so here are the areas that are of concern. We expect a child to know how to request something that's motivating to them. We expect a child to attend to us when we demonstrate an action. So things like that. If you're in this kind of situation where there isn't any screening, so you're not even on the road to an evaluation, still community providers can learn how to use these activities and again can start intervention again even before this whole process starts. And I think it's real important to get to start working on core developmental skills in a timely way with children with autism before you get the diagnosis. And again, thinking about, well, I'll talk more about the prevention. So when we get younger than under 24 months, it's a special case. It isn't the same thing as preschoolers. And we need to think, I think, very carefully about whether the service delivery system that we have now is working. And my current, I don't know, I guess this is my soapbox now, is that we probably need to, if we're going to try to serve these children in the most, in an effective way, that we may need to stop thinking about diagnosis and intervention, because we really want to catch them before the symptoms are full-blown, and start thinking more about risk and prevention. And I know that doesn't fit well with many state funding and implementation, although I understand Minnesota is much better in that regard. But it's, you know, it's a real different way to think about it. But I think for autism, it's a shame not to. And we have models for risk prevention. We have educational models. We have medical models. We know about, there's a whole literature on effective prevention. We know that it's important. We know that you need to use adult teaching methods. You need to, that parental engagement is important, that dosage effects are important, that these interventions have to be, you know, you think about when to do it. Timing is important. Staff has to be well trained. So we know, like, so this whole literature really hasn't, like, been smushed into the autism literature yet. The educational model of responsiveness to treatment is an example of risk prevention. So you identify children at risk. This is Lynn and Doug Fuchs have written about this. You provide less intensive strategies for children who still need work. Then you start providing more intensive strategies. We have the medical model of cardiovascular disease, where you identify risk factors. What you're trying to prevent is heart attack and stroke. You identify risk factors. You give some advice regarding prevention and monitoring, and then the intervention becomes more intensive as needed. For autism, we want to prevent functional impairment. Risk factors are failing a screening and having an older sibling with autism. We can implement lower cost prevention models and then see what happens. We may not need to move to a full-blown intensive intervention program for all children. So this is what the risk prevention model would look like in this. So routine screening. Child screens positive. You implement some preventative strategies that will involve the families. You provide ongoing monitoring of process and then of the progress, and then as needed, you provide the diagnostic evaluation and a more intensive specialized intervention. Okay, so let's talk about early intervention and what we know and what we don't know about that. Okay, so let's pretend everything goes well in the identification process, gets the diagnosis, referred for intervention, then okay, so we have a problem because there aren't many services or there aren't many service providers. Again, this may or may not be typical of your area, but it is the case in many states. And there are surveys that have found that under 20% of children under age 3 with developmental delays actually get early intervention services. There are only 35% of states who responded to this survey provide autism-specific services. There's great variability between states and within states, within small regions of states. And compared to preschool programs, the providers for toddlers have less autism experience, and the toddlers receive fewer hours per week of services. So again, we have some work to do there. When we don't give them state-supported services, parents, well, or whether we do or don't, parents, there is an amazing number of interventions they can find out about on the internet. I mean, this is probably 1/10 of them. And parents are in a really difficult position of trying to sort through these and figure out what makes sense, what doesn't make sense, what's good, what's bad, what can work in combination with other things, where to find it, how to talk to other parents. And this is not something they signed up to do. So I'm going to give you, again, I like really simple diagrams for things. So my basic thesis here is that the characteristics of autism have implications for specialized intervention. And both at the behavioral features that children with autism share because they have autism, and then the individual differences that just because one kid is different from another kid. And those two things are going to have implications for how effective a treatment is. So in terms of the shared behavioral features, okay, children with autism are going to have impairments in multiple domains. They're going to have something related to social and language and behavioral deficits. So that means we're going to need a broad-based treatment that addresses many areas and involves many disciplines. Okay, so this is, to me, is common sense, but it's really easy to forget when you get like stuck in that web of treatments. Children, another shared feature is that there are going to be impairments across multiple contexts. So it's not, a learning disability that shows up only in school. It's these things show up in different settings with different people. So we're going to need to teach skills for different settings and promote generalization across settings and people and materials. And then in terms of the individual differences in behavioral expression, just because children are different, they're going to show different, what is that word? Different patterns, different expression of the symptoms of autism, different severity, different manifestations. So no single treatment is going to be effective for all children. Children with autism, there's a saying, if you know one child with autism, you know one child with autism. So there's also the child-specific variability. Again, not in how the autism manifests, but in children have different histories. They have different family situations. They have different temperaments. And all of these things are going to affect how they respond to treatment and how parents can implement treatment and what they feel comfortable with. So you're going to get individual differences in treatment response. So there's not going to be one treatment or one treatment approach that is going to be effective for all children with autism. I mean, that's just makes sense. Lots of differences between treatments in many ways. The scope can be focused or it can be very comprehensive. Many of the preschool programs that have been developed for autism are comprehensive. They address many different areas of functioning. The outcomes, what we are trying to achieve, differs from program to program. Whether the setting can differ, whether it's at home or in a clinic or at school, how intensive it is and how long it lasts. There are 40-hour-a-week programs for 2 years, you all I'm sure know. There are once-a-week programs for 12 weeks. And each type has been shown to be effective for various things. It's who's the target of the intervention. Is it the child or is it the caregivers or is it both? And then, of course, the methodology, which is what gets the most press. So I wanted to mention this. And so behavioral, one methodology is behavioral, and I will put this up. So there's a lot of contention between this, and I think that that's maybe more historical than current. But so behavioral focuses on observable behaviors, principles of operant and respondent conditioning. Developmental is more focused on child development and child-centered approaches. So if you look at them on a continuum, all right, so the behavioral are typically more adult-directed, but the conventional behavioral. Developmental, more child-focused. They differ in terms of who is directing the activities, the adult versus the child. They differ in terms of the materials they use, the setting, the type of curriculum, the strategies, how important it is to build a relationship. But what's happened now over time is that behavioral treatments have integrated more naturalistic approaches. And so the difference between developmental and behavioral is really not, sometimes it's with some behavioral approaches, it's really hard to draw the line. Discrete trial training is not naturalistic, but pivotal response and incidental teaching are more naturalistic, examples of naturalistic teachings. I want to just clarify what I mean when I say ABA, and I am old enough to remember what it used to mean and what it means now. So what it really is and how it started, it's a system. It's a system of concepts and principles and techniques used to understand behaviors and modify behaviors. It includes lots of different approaches. It's not one approach. PECS is an example. Functional communication training, verbal behavior therapy are examples of ABA approaches. And the principles come from the realm of experimental psychology. They've been around and elaborated for decades. So what it is an evidence-based intervention for improving behavior, teaching skills. It's been used with a variety of children and adults and populations, including those with ASD. It wasn't developed for children, for autism. It's been around. ABA, when I use it, is not the same as discrete trial training. It's not the same as Lovas's approach, and it's not the same as a prescription for a 40-hour-a-week program. Okay, but although it gets used that way, so like the first thing, when somebody mentions that, the first thing is what do you mean by ABA that I ask. All right, that we know how to. Well, we have criteria. Wait, did I skip one? No. We know how to measure whether a treatment is effective, and the conventional standards are that you want two randomized group studies where children are randomly assigned to a treatment versus another group, and that show that the treatment is better than a placebo or better than an existing treatment or equivalent to an established treatment. The studies need to be conducted by independent investigators, not just the investigator who developed it, and the studies need to be well designed. And there are lots of criteria in your that for what a well-designed study is. So you can read about those. And this is a specially designed slide for this group. It's very hard to explain to parents who really, they just want to do something now, and they hear from other people, that there have been successes with this treatment for other children, and it's just hard to communicate why it's really important to do research to know what's effective. So this, I don't know if this will work either, but this was the latest thing I tried. Okay, so if you have this grid of whether you try a treatment versus don't try a treatment, and whether the child improves versus doesn't improve. So a lot of times we're just working on the information in this one box. Okay, so we know people who have tried a treatment and they've improved. Okay, and so well, I have 3 friends, and this is an exaggeration. This is like an extreme, and it does not only apply to parents choosing treatments. It applies to me using coldies when I think I'm getting a cold. But we won't go further into that. So if this is all the information you have, yeah, why not try it? 3 kids I know improved. But then what if you find out that 8 kids who tried it didn't improve? I mean, does that change your inclination and the importance of trying this particular treatment? And then what if you find out further that 8 people improved without using the treatment? Then does that, would you make the same decision about the value of a treatment? And that's essentially what the scientific method does. It looks at the changes that are due to the treatment itself, rather than development, rather than any other biases that can happen. The comprehensive treatments for autism, we know that many different treatment approaches have been associated with improvements. As I mentioned before, not many have used rigorous designs. There is no, using the definition I provided, there is no comprehensive treatment that meets the criteria for well established. Mostly because children are not randomly assigned to treatments, or that they haven't been replicated by other group, or that they haven't compared one treatment to another treatment. And that there is a great degree of variability. Some children make rapid progress, some children make modest progress, some make very little. But what we need to know in intervention research right now is this brand name better than this brand name? What we need to know is which type of intervention is most effective for which type of children and for which skills. We need to be able to individualize treatment to the children. Children are different from one another. Families are different. And we need to be able to match the individual children to the treatment that's going to be more effective. We do have information about the common features of effective early intervention programs. This is for the book Educating Children with Autism that was published by the National Research Council. I'm not going to go over these, but they're in your handouts. But we have you know, so we have an idea, we have a consensus agreement at least. And I will also say that the 25 hours per week that's recommended is based on an average. So it's the average number of hours that children interventions that showed success provided. So it's not like it has to be 25. It's just that this is the average number. When we talk about infants and toddlers versus preschoolers, their learning is entirely different. You can't, just like you can't use a treatment strategy for a 6-year-old with a 3-year-old, you can't use an intervention necessarily for a 3-year-old with somebody who's 18 months old. Infants and toddlers have different learning styles. They learn using their senses. They need to explore things. They need real-life objects. Learning occurs in a social context. Maternal responsivity of a caregiver is critical to learning. Memory is short-term, context-specific. So these are all differences that suggest that very different interventions need to be used for these very young children. So the characteristics of interventions are involving the parents, or the caregivers. And this is something that seems to be totally left out of the formula. Maybe not here, but there is a sense that that outside providers need to work with the child, and that a parent doesn't have the skills to do that. But parents are with the child, and yes, there are strategies that they can learn that can help facilitate the development of social and communication skills during everyday activities. So that's something that that needs to, I guess, we need to be enculturated more for that. Play-based fosters social and communication development. Now, when we look at intervention research for younger children, there are very few studies that have been published and very small samples, so we know very little. But there are studies that are being conducted that are looking at different interventions. And all of these studies, these are all funded by Autism Speaks, and we have meetings about this. And the treatment approaches are very similar. They have different names, but they all work with the parent. They all are home-based for at least part of the time, focus on everyday activities and routines. So that's kind of, and they all were developed separately. So there's some validity for that. In early intervention, we need to address the core features of autism: social interaction, object play, communication, both in terms of requesting and joint attention, motor imitation, and then, of course, adaptive behavior. I'm trying to see what I can get done before my time is up. So the goals that we have for children with autism are a little bit, sometimes a little bit different, because you need to start at lower developmental ages. So for social interaction, goals may start with attending to others during interactions, sharing positive affect when they're enjoying something, taking a turn during interactions, initiating interactions, responding to initiations from others, and then generalizing this not just to other situations with the same person, but to different people in the same situation, different people in other situations. So the goals are very different for young children, and they start at a different level. For object play, object play is critical because this is how you learn, you learn how to play, yes, but you learn how to communicate with, if you can play with things, and if you have some skills, other kids can join in, and families, they can become more of a family system in terms of having some shared activities. So it's not only is it, so it's a bridge to many other social and communicative skills. So expanding a child's interest in toys is often one of the first goals. Imitating simple actions, increasing functional play, developing functional play with dolls or animals or action figures. Increasing flexibility is often a goal we need to include, and then incorporating adults and then peers or siblings into the play. So the point is that there are, and these are in your handouts, is that there are different things to consider in developing goals. I'm not going to go through those. So just a general set of strategies, because I know my time is up, is that these are things we want to maximize in developing intervention strategies. The child's interest. We've got to pick out things that the child is interested in. If the child isn't interested, I mean, it's play. It has to be play-based. It has to be, we can't tell them what they like. We need to look at it from their perspective and use preferred objects. We need to increase predictability, so create routines. Routines are very important, using the same words initially. Of course, you always want to, you want children to be able to act in unpredictable situations, behave the same way in situations that aren't exactly the same. But you got to start by building some predictability and understanding in there. We need to make sure the child feels successful in the activities. If we keep asking them to point to something and they're not doing it, that's an aversive situation. I mean, children with autism also know when, it's just unpleasant to have somebody tell you something or expect something of you and you don't know what it is, or you can't do it. So we need to provide the scaffolding, and whether it's visual supports or physical prompts, so that they can be successful, so that we can reward them. We have to increase the child's motivation to communicate by being really creative and sometimes a little bit tricky. We can, be goofy in the things that we do. We can put things out of reach. There are lots of ways that we can do this. And then we have to make sure that our expectations for the child's behavior in this situation are clear to the child. And that might involve limiting language, using the same words over and over again initially, and providing visual cues so that the child knows, well, in this place, at this time, with this thing in front of me, this is what she expects me to do. And that's all. Look, I have the sign that says stop exactly when I did that. So thank you. And I also I just need to acknowledge funding sources, because without, we wouldn't have known any of this without research and support from NICHD and the Marino Autism Research Institute, the Department of Education, NAR, Autism Speaks, and lots of co-investigators and graduate students and psychologists. Thanks.